Okay, I'm looking over at the participant list to make sure that we're ready for our panel discussion. And I know we have our first panelist available, and I am going to hand it over to Dr. Jenny Crowley to introduce E.L. Morton.
Thank you, Brian. Okay, so now we are going to transition to our panel focused on stigma as a barrier to substance use disorder prevention, treatment, and recovery. I am Jenny Crowley, and I'm the Digital Storytelling Coordinator for RCORP-ETC, Project Hope. We have 4 wonderful speakers with us today. I will introduce each speaker prior to their presentation, and we have 6 minutes for each speaker. I will unmute myself and cough loudly, speakers, when you're at time. So wrap up if you hear me jumping in. After everyone has presented, we will have a discussion amongst panelists and then time for audience members and questions. Audience members, if you have questions, please put them in the chat box, and you've already been doing a great job of that. I will make sure to field questions to our participants at the end of the session. So with that, I would like to introduce our first speaker, E.L. Morton, who is going to present on rural despair and drug misuse. E.L. Morton is the mayor of Campbell County. He is a graduate of the University of Tennessee and retired Lieutenant Colonel, U.S. Army. E.L.'s awards include the 2013 La Follette Press Businessman of the Year, the 2014 Chuck Davis Tourism Award, the Combat Infantryman's Badge, Ranger Tab, and Bronze Star. Thank you, E.L. Morton, for joining us this afternoon. Take it away.
Thank you. I have a few experiences in my past, but very few of them tied to mental health or substance use disorder. But I do represent 40,000 people in the middle of the RCORP footprint. And I thank you for this opportunity to have this discussion and learn so much. Leslie, I always learn so much when she speaks, and today was a plethora of information for us all to take and to digest. But just from our perspective, Campbell County has been one of the hardest hit across America by opioid use disorder. It really feels at several points that we were targeted by an industry and a sales force. And I think that's fairly well documented by the producers of OxyContin. And then from the year 2000 to now, we've struggled, as so much of the area has, with the methamphetamine rise and fall, but constant presence out there. And so we continue to struggle with opioid problems. It manifests itself in a population of folks that I think represents probably 8 to 10% of our potential workforce, justice involved. It manifests itself in about a $15 million jail that the taxpayers have shouldered. It manifests itself in a lot of human suffering and difficulty in growing our economy for all those jobs and fair pay and quality education that Leslie mentioned out there that we know are parts of the solution for fruitful, healthy communities. We are a former tobacco and coal economy, and our people have been labeled throughout the processes of those shrinking economies at no fault of their own, hardworking people labeled as the producers of a poisonous tobacco product and the miners of a poisonous coal product. So we've lived through some stigma as well through those processes. And our economy that we're left with is a relatively competitive manufacturing base and retail, but we are evolving toward a tourism economy. In fact, we led the state of Tennessee in tourism growth dollars this year with $4.1 million growth in sales over last year. We need workers to provide that tourism product, and we have so many of them locked up in a justice-involved situation that are facing all the challenges that we've discussed. During the COVID phenomenon, we've experienced a surge of people found dead because of fentanyl. Fentanyl laced into heroin products and other products out there. And it's just really an intense time for us over the last 12 months for sure, to see even more consequence for people who are using drugs and facing overdoses. I think the stigma, it's an evolution. The public frustration goes in a lot of different directions. The scenario that we're seeing with the crime attached to misuse, it's driving theft, domestic and child abuse, homelessness, and a whole lot of consequences out there that we as a society really don't have anything to address it. It's difficult for the average citizen to separate the frustration from the people who use drugs. We have some folks this morning on our local news source. A fellow was arrested for the 80th time. And so criminalization, as we look at it, you've got to determine what caused that. But there's criminalization on a couple of sides. We've got opioid producers, Purdue Pharma, just as an example. I can't find any other way to describe them other than call them criminal for what they have done to my county. And so we're seeing some judgments come through the justice system that should manifest in some dollars. It should be resources to help us to address some of the challenges that we're facing because their product was sold in such a force and produced in such a force on the order of 700 doses per citizen in the state of Tennessee at one point. That's criminal. So there is a place for criminalizing some folks in this business. The users who lose their faculties and meet the qualification for crime and are addressed for it, that's the discussion we're in today, and I'm hearing a whole lot of different approaches about it. The public at large, it's in a couple of groups now. There's one group that says good riddance and punishment to all who fall in that category. And I'm not, and that's, we talked some, Leslie talked a lot about how to address that. And I like to be nice to people rule. I had an aunt that passed away a few years ago. And the one thing that I remember her telling me from the time I could understand her speaking was be good to people. And so from my upbringing and raising, nobody has the right to do anything but be good to other people. And so there is another group in society, in our community, that's growing, and it's the group that says, let's do something about this. And the reasons why are they've gotten beyond their frustration for one reason or another. They're bringing human sympathy. They understand that it makes economic sense that you're spending more money when folks can't control the substances they're putting in their body, and workforce availability. So I think there's some recognition out there for that. And but I do think that we've got some resources that we can put to work out there. And so I'm getting a high sign, but glad to continue the panel discussion.
Thanks, Mayor Morton. And we will have plenty of time for more discussion and questions. So I know you'll get to elaborate on your thoughts here in a few minutes. Okay, our next speaker is the Honorable Dwayne Sloan, who will be presenting on Incarceration is Not Treatment. Judge Sloan, a former drug trafficking prosecutor, was first elected to the 4th Judicial District Circuit Court in 1998. In 2009, Judge Sloan co-founded his judicial district's Drug Recovery Court. Presently, Judge Sloan serves as the chairman of the Tennessee Judicial Opioid Initiative, chairman of the 7-state Regional Judicial Opioid Initiative, and chairman of the Tennessee Judicial Conference Problem Solving Committee. Judge Sloan has also received the Tennessee Public Health Association's Visionary Award and the Tennessee Association of Alcohol, Drug, and Addiction Services Voice of Recovery Award. Thank you for joining us this afternoon, Judge Sloan.
Great to be with you. I've been asked to discuss the fact that incarceration is not treatment, but I want to really focus on the reality that we do encounter people in the criminal justice arena. And this first slide is a quote of Dr. Nora Vocal. Many of you are familiar with her. She basically pioneered the brain science of addiction. I serve on the NIDA J-COIN, that's Justice Community Opioid Innovation Network Practitioner Advisory Board. In our inaugural meeting, Dr. Vocal asked this question: how do we use what we know about the brain science of addiction to guide our criminal justice responses? And I think if we ask that question at every intervention point, that we can really maximize our opportunities to serve this population. Next slide, please. My own perspective is this, and that to effectively address the opioid-driven addiction crisis, we have to go as far upstream as possible, meet people where they are, and provide hope and healing. Next slide, please. And so we need to maximize our opportunities in the criminal justice system at the different intervention points. Next slide. So this is a sequential intercept mapping model. And if you look at the screen there, you'll see the different intercept points 0 through 5. We would love to be able to help people before they ever become justice involved. At intercept 0, that's where our community care is. Where the providers are, where the faith-based organizations are, where harm reduction services are, where we work and play and go to school. But when you become justice involved, it's typically 911 is called and you have an encounter with a police officer. So now you come at intercept 2 and 3, and that's the initial detention in jails. And that's really where we're focusing, or I'm going to focus the remainder of my time. But so as the mayor was talking about, our jails have a lot of people that are there, as we all realize, that have substance use disorders, most of them with co-occurring mental health disorders. And so what do we do with that opportunity? And that's intercept 2 and 3. But intercept 4 and 5 again so it'll be when there's reentry planning and they're coming back into our community, but now they're being supervised. So how we take advantage of these opportunities. Next slide. What we are doing here in 2 of the 4 counties that I serve as circuit court judge, we utilize the essential components of the most successful recovery-oriented compliance strategy, and they are as follows. If you'll just click that, there we go. When they are in custody, we haven't, or they encounter us in our criminal justice system, there's an accurate assessment done by a criminal justice liaison or a medication to assist opioid use disorder treatment navigator. And then there's a referral to the appropriate level of treatment for the appropriate amount of time when they come back out. Number 2 is frequent accountability. And 3 is a big stick or leverage. And number 4, and this is that's the next click, is relationship. As Leslie Marie said, and the mayor said, and I agree wholeheartedly, be nice to people. I try to teach my children, treat others as you'd want to be treated. And that's what we try to do and model in the 4th Judicial District. But this approach is the same approach as the programs that have the most successful long-term recovery, being airline pilots and physicians, boasting over 90% of 5 years or longer. But again, the secret sauce is relationship. Next slide. So how this works is typically on the left, you'll see our criminal justice liaison or TENROC's liaison, Elizabeth Francis. She will meet with people typically when they're arrested, for example, a violation of probation. There is an indication they have a substance use disorder. Ms. Francis, who works with Helen Ross McNabb Center, meets with them and does. Ms. Francis is a master's level licensed clinical social worker, develops a treatment plan for them, and then does a warm handoff. So there's no gap between leaving jail and entering into the best available services that we have for them to treat a substance use disorder and co-occurring mental health disorder. Those that treatment plan becomes a condition of their release, whether it's probation or pretrial. And then to the right, some people will be in jail longer. So we've just launched, after 2.5 years of a lot of hard work and dedication by some wonderful people, being able to provide medication to treat opioid use disorder inside of our local jail in Jefferson County. We started out with maintaining people that are already prescribed. However, we have now, I think, somewhere between 15 and 20 people that have been inducted while they're in jail. The same process will take place once they're released into the community. There will be no gap in services made available to them so that there's continuity of care. Next slide, please. So when they come back out into the community, then that second element that I spoke about being frequent accountability, the person will show up to their community supervision officer, either state Tennessee Department of Corrections probation or community corrections officer, and the officer makes sure that they are complying with their treatment plan. But again, the community supervision officer is trained in at least basics of substance use disorders, learns how to speak appropriately with that individual, but they're developing a relationship. They're developing a trust with that person that really pays the big dividends. But to make sure that they're complying with they're showing up where they need to show up and doing the things they need to be doing. They do screen them randomly and at scheduled times. We're not screening them, try to catch them, but you have to know what's going on with them, and that's a good tool and a valuable tool. And the people involved in our programs would tell you that as well. Next slide, please. So we have the people that participate in our programs come back for compliance reviews in court, and and I have a brief conversation with them. It takes 3 to 5 minutes. I see over 350 people in just Jefferson County and Granger counties alone, and these are all felony cases. About 25% of the felony supervised release population in these two counties. And it takes me 3 to 5 minutes to have the conversation. But really, the biggest tool I have on my belt is that relationship that is built and the positive affirmation that I give them for a job well done. We've reduced our crimes charged in Jefferson County over the last 3 years by 33%. We have no jail overcrowding in Jefferson or Granger. We've reduced overdose deaths by 50% over a 5-year period of time in these counties, where it's going the other direction in most other places. We've had over 100 healthy births of children. And so this works. But we're just trying to meet people where they are and provide them with hope and healing. Next slide. I think that's it. I think I made it my 6th.
Thank you so much, Judge Sloan. Okay, our next speaker is Dr. Bandyopadhyay. Jonah Bandyopadhyay is an Associate Medical Director for the Division of TennCare, Tennessee's Medicaid agency. At TennCare, Dr. Bandyopadhyay serves as the clinical lead on various projects, such as TennCare's opioid strategy and maternal health strategy. Also known as Dr. B, she works in close collaboration with TennCare's Division of Quality Oversight. Dr. B is a board-certified OBGYN who completed her residency at the University of Florida Shands Hospital. After a few years in private practice, Dr. B pursued a Master of Public Health from Georgetown University Milken Institute of Public Health and transitioned from clinical medicine into health policy. Welcome.
Good afternoon, everyone. Next slide, please. So in order to talk to you about reproductive inequities, I need to give you the context of TennCare's role and efforts in this space. And so this opioid strategy dates back to 2018, where we took a public health approach. Primary prevention, which focuses on policies to prevent the problem from developing from the get-go. Secondary prevention, which identifies individuals who might be at risk or on the trajectory towards opioid misuse and interventions there. And tertiary, actually treating individuals with substance use disorder, ensuring access to high quality providers. So I'm really going to focus on tertiary prevention today, but happy to answer questions of any of these three. Next slide, please. So while TennCare covers all types of treatment, including modalities from medically supervised withdrawal to outpatient MAT to inpatient centers, I am going to focus on MAT, also known as MOUD, which is medication-assisted treatment. And the reason why I'm focusing on this is where it intersects with individuals or women who are needing treatment for substance use disorder during their pregnancy. We know that women who are on medication-assisted treatment are more likely to have a term baby. They're more likely to have a baby with increased birth weight. They have a decrease in symptoms related to NAS, or also called NOWS, which reduces the length of hospital stay for that baby. Also reduces the chance that that mom is going to have a relapse or a relapse-associated death. So our goal is to support active recovery through supporting the providers who deliver the care and also supporting the member who's trying to find access to those treatments. In addition to that, we also support payments for things like rooming in. We know that rooming in the hospital also increases the ability for moms. Supporting moms throughout the postpartum period in trying to navigate transition from their MAT provider who may have been their OBGYN to another MAT provider, or transitioning into a Thank you. So I'm going to highlight three different programs that we have. This is called the BEAST, and this is a network within a network, so it's pretty much a sub-network. So our goal here in developing a B-Smart program was identifying the high-quality providers. And there was a point of time in our state where we saw a lot of cash pay and buprenorphine. And a member who got care from a Dr. Smith may have a very different care they receive from a Dr. Jones. And to solve for this, we created this sub-network known as B-Smart. What it is? Well, we asked our providers to voluntarily raise their hand and agree to a program description that TennCare created. And they, in addition to agreeing to that program description, agree to transparency, accountability, where TennCare and our managed care organizations can actually have insight into the care they're providing. And in return, the providers have significant flexibilities that other MAT providers don't have. Next slide, please. In addition to the B-Smart program, which is focused around buprenorphine, we also have a program description built out for naloxone and then also one for methadone. Again, my point here is that we are trying to support all different forms, and this will eventually tie into the topic that we're trying to talk to today. Are built on evidence that are based on exam and recommendations. Next slide, please. So this is just a snapshot of where we are in the state as a result. Voluntarily raised their hand and said, I attest to this higher quality care. Just a quick snapshot. And actually that lower slide, it should be 15 contracted methadone practices and over 280 B-Smart providers. There are other MAT providers, but these are the high quality ones who have come forth to say, we agree to providing this service, and TennCare has the transparency to be able to say, I have the test. Next slide. Okay. Medicaid, we focus on access, and that's really what I tried to lay out for you, all the things that we're trying to do to ensure access to these services. So what are the challenges that they're still seeing? There's no question that the stigma in the community and the system continues to plague us.
Dr. B, your sound is cutting out, and I'm wondering if it would be better if you stopped sharing your video. Thank you.
Okay, it's Bluetooth dying. So sorry, I was speaking about the stigma that continues to plague us. So we recognize that members are delaying care because of the stigma and the trauma that they faced in the past. We recognize that they have challenges when they go to a pharmacy and unable to fill a prescription for MAT because of the bias against that particular drug. So there's no question that this is a challenge that we face. Despite what we can do in terms of access, we are unable to address the effects of stigma on our members. Next, providers declining to treat pregnant women. Oh, sorry. We continue to see this. There are providers who say, we'll provide MAT or provide treatment for OUD or SUD, but we won't see pregnant individuals. So what TennCare has done to overcome this is identify those providers who are willing to treat pregnant women. And therefore, when we do face this, we can connect our members to that particular provider. We can say, we know this Dr. B out here will see you because she provides this care to a pregnant woman. Let's do a warm handoff to that individual. Transportation for moms is incredibly difficult, and this is not going to be difficult to grasp. But imagine you have a newborn that requires a car seat, or imagine you have more than one kid and two young children. TennCare offers various forms of transportation, including bus passes, rideshare vans, Lyft. However, what can happen is our member may not be aware that there are various transportation options. And because of their unawareness, don't reach out to say, I need to take 2 kids or I need to take 3 kids to my appointment. Do you have an option for me? So there it's really about a matter of knowledge and being able to inform our members, which we try to do, that there's multiple transportation options that exist that we can work with you. We just need to know so that we can connect you to the right service. And the last one is childcare, which is incredibly challenging. Imagine a mom has 2 kids and both of those kids need to come along with her to get treatment, whether that's a doctor's office. After the doctor's office, it's counseling. After it's counseling, they have to go to a pharmacy, and the ability to do all of those things while having children in tow. No question that's a significant barrier that continues to plague our population that TennCare struggles with. So I think I'm up on time. So just wanted to say I'm happy to answer any questions and discuss these. And if you have suggestions, comments, TennCare is always willing to listen and hear. So I'm going to actually add my email in the chat box so that if you have any comments after this, please share them with me.
Thank you. Our final presenter today is Brittany Hudson, who will speak about punishment but not treatment for pregnant women. Brittany Hudson is the mother of a 7-year-old daughter and 4-year-old son. Brittany was the first woman to be charged under Tennessee's fetal assault bill, which sunsetted in 2016. Brittany is now in recovery and an advocate for mothers struggling with substance misuse. Welcome, Brittany.
Hi, thank you. Can you see me? Can y'all hear me?
We hear you, we see you.
You can't see me?
We can see you. You look great.
Okay, good. Thank you. So yes, I was one of the first women charged with the fetal assault law, and I have during that time, I had TennCare as well, and I had reached out while pregnant, which was a barrier because I was pregnant and I was too far along that people didn't want to take me because I was, I guess, a liability. So after I had my daughter, I ended up a month later deciding that I was going to die and I needed help. So I went to Nova, and they basically told me good luck, that there was nobody out there that would be really, there's nobody that wants to help. You know, it's something that we all talk about, but their lack of treatment options. And luckily I had a very good support team, and my mother, being her, would not let me leave a hospital until somebody got me help. So I ended up in Buffalo Valley for less than 24 hours, and TennCare decided that they didn't need to pay for my treatment and sent me on my way. And I ended up in more trouble. So I ended up in jail and got to detox there, which was not fun. And I ended up coming out of jail. I stayed lock and key with my mom for about 2 months, and then ended up finding a halfway house that ultimately saved my life because, you know, instead of jail, I truly needed treatment, but there was no resources. And then about 9 months later, I started working in recovery field at Renaissance Recovery. Unfortunately, they don't exist anymore, but I was with them for about 3 years, and I saw it on a daily basis where, you know, these girls would come in and they were just, there was so many barriers to getting them into treatment. And basically they were looking with the fetal assault law at the time, they were looking at either going to jail or finding help. And at the time, this was in 2016, it was hard to find people that wanted to take them. You know, luckily now I have my life on track, but a lot of people don't have the support that I had with my mother, the community, people in the community. I ended up meeting people with Metro Drug Coalition. So that, you know, they really helped me find people to navigate me to get me where I needed to be. And like I've heard multiple times today, mental health and behavioral, or mental health and substance abuse, they're hand in hand. You usually don't see one without the other too far behind, especially untreated. And that was another thing with finding women who had they needed, you know, mental health along with substance abuse. And a lot of people didn't want to touch that. So I don't work in the field now. I still advocate for mothers. I still strongly believe that there's ways to get ahead of all, to even deliver a baby with NAS. I think there is ways, and unfortunately we're just not completely there yet. You know, I still have girls reach out to me just because of my story, and I still share it to a lot, looking for treatment and access. And I still have really big hurdles finding them during this time. I think that's really all I've got.
Thank you, Brittany. We really appreciate hearing your story.
Thank you.
So now we will go on to a panel discussion. I have some questions to pose to the whole panel, and we will, I also have received several questions in the chat for individual presenters. But to begin, I just think it's so great that we had these 4 panelists here today sharing their different work in different areas related to the judiciary, related to TennCare, et cetera. So the first question I want to pose to all the panelists is, you know, what partnerships would you like to see among different stakeholders? Or alternatively, are there partnerships that you can share that are success stories? I want to try to facilitate and build on the great knowledge that we have in this room to think about how we can work together to make a difference. And again, this question is posed to any of the panelists.
Jenny, this is Mayor Morton. I'll jump on that one. We got to mobilize new assets. I've talked to this group before. Public lands are available across the state of Tennessee at no cost to the public. Most of them are in wildlife management areas, and my county particularly has lots of those, but very close to I-75 and infrastructure. We need purpose-built facilities. We lost our mental health hospital in Knoxville over a decade ago, and we just haven't replaced that capability. And it was meaningful, even though it was expensive, but we've had no resource there. So I would like to look at the Tennessee Rehabilitation Center footprint under that concept to bring public lands and purpose-built facilities into a reality. Governor Lee has emphasized rural communities like mine throughout his tenure, and I think the state leadership is postured to support something like that. But the Build Back Better grant cycle that the University of Tennessee is partnering with Oak Ridge National Labs is an opportunity to address this. And we talked with Dr. Zachariah at ORNL. We're partnering with, like I said, UT, the East Tennessee Development District, and all the county mayors are pushing real hard to compete for that $1 billion grant for each of 5 years. So $5 billion in our 16 county area would be available to improve life, not just improve the workforce going to Oak Ridge National Labs, but to improve life. So there's some really big partners out there. And the opioid lawsuits are coming to an end, and there's some cash that's going to flow out of that. So I think we need to put all of those to work, purpose-build some facilities, hire some medical practitioners and mental health care practitioners, and get on this problem and address it.
Wow. Yeah. Wonderful, Mayor Morton. What great ideas. Others on the panel? Do you want to jump in and talk about working together?
Yeah, Judge Sloan, Mayor Morton, that I love what you had to say, and I couldn't agree with you more. What opportunities. I wanted to just kind of briefly describe the partnerships that we have in place that have proven to really be the what has made our program so successful. So we have in place the partnerships with Helen Ross McNabb, with the Criminal Justice Liaison, that develops the relationships with the corrections staff inside the jails, with the district attorney generals or assistant district attorney generals and the criminal defense bar. We have a network of providers, trusted providers that provide medications to treat opioid use disorders. We have a network of partners that we refer to for residential recovery. And we provide education to law enforcement and first responders that help address issues related to stigma. And they're meeting people where they are on the streets and able to then make referrals in order to coordinate or get a first, to take the first step in obtaining treatment. But those are just some basics within the criminal justice system that have paid big dividends for us. And it's people actually see over a period of time how people's lives are changed. And so it's really created a philosophical and cultural shift in our counties. And I'm happy to say it's being replicated in at least 11 judicial districts in Tennessee and in other parts of the country. And we also have a partnership with the Department of Health, with our local health departments, where we refer to obtain education about harm reduction strategies and how to obtain treatment, for example, for Hep C and long-acting reversible contraception.
Thank you. Dr. B, did you have a contribution?
Sorry, I can't get my video back on. No, I think this has been a really robust and great discussion. In regards to someone just, sorry, it was, I think Sloan just commented on the availability of LARCs. There's been a lot of interest around the availability of LARCs within the state, and TennCare is doing a lot in that space as well. So I'd love to be able to share more of that information with this group. There's a partnership with a specialty pharmacy who's allowing for the availability of LARCs to exist in offices without a traditional buy and bill method. Without getting into the details, it's a barrier, it's a challenge for our providers, the current model that exists. And so to be able to walk into a provider's office and say, hey, can I ask for this type of contraception and get it at the point of care, again, meeting the patient where they are, is something that we have initiated in April of this year. So I would love to be able to share that information with this group. I'm happy to send an email with specifics because it's not quite related to the SUD world, but happy to share that with this group.
Right, and there will be a follow-up email after this presentation with a link to the recording. And so there may be ways that we can get some of that information out to our audience members. Thank you, Dr. B. Another question that I wanted to pose to the panelists is actually a follow-up on something that Dr. B included in one of her slides, that stigma is in the community and in the system. In other words, some of our existing policies and programs may stigmatize individuals with substance use disorder, but people also experience stigma in their daily interactions. So knowing that there's stigma in the community and in the system, are there ways to address both, or do you think these require different solutions?
This is Mayor Morton. I'll give it a shot there. What Brittany did was power through it. And her personal constitution gave her the power and the support network that she had. That's how it has to be done now until we can reduce resistance on the other fronts. But I don't have the answers for a whole lot of what we talked about today, but Brittany's proof it can be done. It takes superhuman strength to push it through like that. And I'm not sure, the percentages say not everybody's going to be able to do it. So, but I just think Brittany's a great example of somebody who succeeded and proved that it can be done, along with her support network.
This is Dr. B. I'd like to chime in as well and say, I believe it requires both. And I hear anecdotal stories from our members that directly correlate to both. For example, an individual not wanting to inform family members or request support from family members because of the stigma within their own mother, sister, brother, etc. And of course, policies that exist that we've already talked about that exist, in the system. So I think there needs to be different approaches to address both. One is community related, normalizing acceptance of all the things that we've discussed today. And the second is all of our systematic policies that might be in place and taking those down.
Thank you. Yeah, I completely agree that we need to confront the stigma on both fronts. So are you going to go in, Judge Sloan?
Well, just briefly, there's a couple of things that we're doing locally, or actually in East Tennessee. Dr. Kelly Moore with ETSU obtained a NIDA called JRIG grant, where we are training different the stakeholders in criminal justice about how to the goal is to destigmatize people with substance use disorders and co-occurring mental health disorders. We've been doing this for quite a while, so the idea is that you take our stakeholders and then we're comparing them against hopefully the improvement in the engagement and perspective of the stakeholders, and I think 5 other judicial districts. So be looking for the results from that sort of training. with regard to people that are justice involved and the stakeholders that meet them at different contact points. With regard to stigma, there's one thing I want to say, and don't anybody throw tomatoes, please. But when we're talking about stigma and people involved in criminal justice, we need to keep in mind that there are really real victims. This is not just like a kidney disease in the sense that it affects your brain. And I don't know anybody with diabetes that it leads them to go steal from their mother, burglarize their neighbor, or rob and murder their local pharmacist. So we've got to keep that in mind and acknowledge it, while at the same time understand that the disease, and I don't have any hesitation calling it a disease, is treatable. And like Brittany, people do recover. And so our local, like assistant district attorney generals, are able to give the stories like Brittany to the victims of crimes to let them know that this does, in fact, decrease crime. There's going to be reduced victimization and people get well. They go to work at one of Mayor Morton's manufacturing jobs or new tourism job, and you're paying less in taxes.
Thank you.
And I'll add just a little bit to that. Springs of Life is a men's recovery ministry in Jellicoe that has started a landscaping company for those who progress to the point where they can function. Entrepreneurial spirit is strong in that recovering group. The motivation is extremely strong, and the creativity is extremely strong. And the public respects the daylights out of that. I know that's on the other end of the spectrum, but there are really good news stories out there for folks that are coming back in and picking up their work life and their family lives and making it work. And that gains a lot of support from the community. I'll say that.
Brittany, I wanted to make sure you had a chance too to reflect on stigma and potential solutions.
Yes, I mean, I'm with them. It doesn't just take, the doctor telling you need to do this. It's going to take probation officer, judges, counselors. It's just, and I mean, we have a problem. We have to accept that there is a crisis. We don't have to like it, but we have to accept that people are sick. I mean, I was sick and now I'm better. And recovery is not something that just happens overnight. It's taken, I'm coming up on 7 years in January. And, and as an addict, and when I was first getting clean, it's almost like every hurdle that hits you. And if you don't have support to fall back on and people that are, care about you and care about your recovery, you're just going to fall back into the same vicious cycle that it never ends. Because unfortunately, people who are sick, they're fragile, they have no hope, they're scared. I mean, all they know is, wake up, use drugs, and, over and over. It's like Groundhog Day, over and over for them. So, it just takes a village, basically, to help these people.
Thank you. Now we have several questions that have come in from the chat that are directed at individual panelists. So I will begin with Judge Sloan. I received a question asking you to review some of the outcomes for people associated with drug recovery court.
Well, if I'm understanding the question, review some of the outcomes, meaning some of our positive stories.
Positive stories. Mm-hmm.
Right. So it's drug recovery court is a closed, meaning there's an endpoint after 4 phases of really intensive accountability. Drug recovery courts are meant to serve high risk of recidivism, high behavioral health need population. So it's when you think about people on felony supervised probation in Tennessee, there's 78,000 people. Probably 46,000 have a substance use disorder. 2,000 people are in drug recovery courts, and that includes misdemeanors. So we're really focusing on this population, but through this and the provision of the accurate assessment, the best available. We want to have the appropriate level of treatment. Unfortunately, still in Tennessee, that's not always obtainable, but currently in today's world, we do have much greater access to services. But again, it's we're making sure that they're getting the services. We're making sure that they're showing up when they're supposed to show up, and we're going along beside of them and encouraging them and developing that relationship with them to where by the time they're with us for 6 months and they're stabilized, they should be in the workforce if they're able to work. And by the time that they complete drug recovery courts, then commonly they are reunited with their families. They have their children back, and they are living life as a productive, tax-paying citizen that you wouldn't know that they had a substance use disorder or co-occurring mental health disorder if you're standing next to them in line at the grocery store. They do not, and they're much less likely to recommit another crime. Mm-hmm. Small fraction of the average percentage.
Great positive outcomes. Thank you.
They might relapse, but they come back to us. They don't stay out.
Thank you. The next question is for Mayor Morton. Mayor Morton, what are the major barriers to getting people in Campbell County the treatment they need?
Mental health practitioner availability. Losing that regional facility in Knoxville was huge to us, but I know folks that had mental health needs that weren't necessarily in a drug use situation that facility provided for. Our jail population it is 40% of them have a mental health need, and so that's why I say purpose-built facility somewhere in our public land out there that is not so far away from the rest of the infrastructure. I think we've mobilized several people in the last 5 or 6 years that want to help. We just we might be well served to build a new plan of how we're going to do it. I think we know what the population is, but we need to sit down as a community and bring all the willing people in and just put the goals out there. We haven't talked so much about succeeding. We just want to overcome and get out of the syndrome. But I think we have to articulate a vision that says Brittany's going to use her Tennessee Promise Scholarship or Tennessee Reconnect Scholarship and go out and get a 2-year degree. And then she's going to move over to UT and she's going to finish a 4-year degree. There are examples of people in plant manager positions and business ownership out there who've come through this struggle. So accentuating our success stories, and they do exist. They're in small numbers. I think we have to paint that vision of success, of family success, and get past the frustration of the immediate struggle.
Thank you. The next question is for Dr. B. Dr. B, is TennCare taking any action to address the widespread issue of pharmacies often refusing to fill valid buprenorphine prescriptions for people in addiction recovery?
Hey, thank you for that question. So, as you probably know, pharmacies are as a licensed pharmacist or the brick and mortar of the pharmacy has the autonomy to refuse any prescription, and that would include buprenorphine. So unfortunately, TennCare does not have any levers in that particular situation when a pharmacy declines to fill a valid prescription. So this relates back to the systematic and community stigma that exists we recognize there's stigma and bias within the within the pharmacy community of not wanting to fill those. And so perhaps further education on the benefits of those medications, education and training during pharmacy school might reduce the impact of that bias. And another is, of course, any policy that the brick and mortar might have about those prescriptions as well. But again, those are not, unfortunately, under the purview of TennCare.
I have a follow-up question for you as well. Could you speak to the ways that mandatory drug testing for TennCare coverage of MOUD services impact pregnant people who use drugs? Are there ways that TennCare can mitigate harm and prevent people from feeling further stigmatized?
Thank you for that question. TennCare does not have any mandatory drug testing policy. So any drug testing policy that you are seeing is not required by TennCare. Perhaps it's the policy of the provider personally. Perhaps it's a policy of the facility that they work with. But TennCare is not requiring mandatory drug testing. That said, I saw the question, we certainly support any individual who continues to have positive drug screens. We recognize that recovery is it's a process. It's not a steady, one-way path. There are going to be times where the individual takes steps backwards and might have positive drug screens again. That's part of the recovery process. And TennCare recognizes that. That is not part of our program. So sad to say that we can't change that either. What I can say is we are trying to identify those high quality providers. And when someone says, hey, Dr. B, I really need to find a doctor for this person, they have this problem, so that we can push or shift them towards the individuals that we have identified as that networked high quality provider, and perhaps avoid these scenarios where there is a provider who's requiring taper or refusing care if there's a positive drug screen.
Thank you. Thank you for clarifying that. And then a follow-up question for Brittany. Brittany, I know you're actively engaged in advocating now for women and mothers who are struggling with substance misuse. How do you draw on your prior experiences to inform your activist work now?
Really, I just share my story and can relate. I know the feeling of being separated from your child. I know the feeling of not taking your child home from the hospital, but then I also know the feeling of being able to take your home from your child. I do have a 4-year-old too now that I got to take home from the hospital, and I have so I don't know. I relate when I have girls reach out to me and say, I'm struggling. And luckily my story has been no secret. I've shared it from the beginning, and that really does help, because I know where they came from and I know where they can be.
Thank you. Are there any more questions that people would like to pose to our panelists? We have time for 1 or 2 more questions.
Jenny, I want to throw out just one comment there. I've got a med school across the county line at Lincoln Memorial University. I want to make sure they're in the discussion. They're part of the solution for this challenge.
Yeah, I'm glad you're acknowledging other players in this space who are doing important work. Thank you, Mayor Morton. Mm-hmm.
I'll make a comment about, there is an MCO, AmeriGroup, that is actually partnered with us with our jail initiative. So when someone is, we do a brief screening. Basically, have you ever used opioids? You ever been dope sick? You ever overdosed? Would you like help? And the answer is yes. Then they see the MOUD navigator, because a lot of people are going right back out into the community, and AmeriGroup has someone that we were partnering we're partnering with the Mayor Group. We're just getting ready to launch this, that they will have a case manager go alongside that person and continue to manage them. And so we'd like to see that replicated.
Okay, well, for our presenters, I hope you take a look at the chat box now that you are done presenting. We've had so many supportive words come over the chat box, people thanking you for sharing your insights. And then, Carol, are you ready to take it from me?
Yes, I am. Thank you. So I want to thank all of you that are signed on to today's policy forum for your participation in your program. I will echo the words that what you have put in the chat and what you've offered there is so rich, and it will help to extend the work that RCORP is doing, as well as the work that's being done in the community. So thank you again for your participation. Today, we aim to chart a path to health equity. That was what our mission was. That's what we started out with. The lever that we use to dismantle societal barriers is policy. Public policy is most simply a government's response to societal problems, and we certainly have covered a broad complement of problems today. We must promote policy change to promote equity. They go hand in hand. So I want us to take a pause and think, so how do we respond as communities in East Tennessee? What are the specific actionable things that we can do? What actions can we take? So some people might say it's a little risky. I don't think so. I think at this juncture, if you have a brief comment about how do we respond, what can we do, and perhaps try to prioritize what you say. If you'll raise your hand, we'll ask you to speak out to the group. I'll start. For 3 years, and today Leslie Marie echoed the comment that Medicaid expansion would take us a long way with providing treatment to people with substance use disorder. That's an actionable recommendation. What are the other things that we've discussed that we could address through public policy?
Carol, this is Mayor Morton. I think there's some validity in pushing for the community development block grant as well from the federal government for a statewide solution.
And I've heard your one of the fellow mayors from Scott County say the same thing. Would you just say very briefly how that would help?
Well, those funds are fenced until Tennessee does the traditional Medicare expansion, but they are still designated for the state. And so receiving those in the form of a community development block grant would still allow us to use them in the state.
Okay. Okay, and in part of it's addressing social determinants of health, not just addressing treatment for people with substance use disorder. Is that correct?
Oh, it would be the entire system, entire Medicare system. Yes.
Okay. I see some things are coming in the chat. We can also do that, but very open to folks opening their mic. Elliot, did I see you had a question, comment?
I turned on my video, but I'm happy to share. But I did comment earlier. There is I wrote a legislative proposal to decriminalize fentanyl test strips, which are now allowed to be purchased with federal grant funds. They cost about $1 each, and given what we're seeing with counterfeit prescription drugs that are especially needed right now, our state used to distribute these as of 5-6 years ago, but stopped when they were found out that it was against state law under the drug paraphernalia law. So we worked with some folks in North Carolina to figure out how they were successful a couple years ago in passing this as part of a package. And this was, it ended up being a proposal submitted through the Department of Mental Health's Planning and Policy Council. And it was the first ever proposal I'm aware of that actually made it all the way through the process and was sent on by the commissioner to the governor. And it's the only legislative proposal that the Department of Mental Health and Substance Abuse Services has taken on at all this year. So we're hopeful the governor will adopt that. So that is certainly good. We talked about the Good Samaritan law needing changing to remove that second or third or however many other times people may want to help save someone's life. They should not be punished for that. And another initiative too, that I think that's really important is I don't know of any community in the state that has a substance use specific pre-arrest deflection program, meaning when someone calls 911 or otherwise engages with law enforcement, how can we make sure they don't get arrested and enter the criminal justice system? There's a lot of models nationally. One is called LEAD, Law Enforcement Assisted Diversion, for example, that are working. There's a lot of data behind these models, and we're looking to find a community that is willing to pilot this. So and we'll provide some free support. So those are a few things. Also, one more thing everybody here should know is I know in East Tennessee, Knox County has a overdose fatality review team. Davidson County here in Nashville also does. And those folks are looking to see how we can get a piece of legislation filed that will allow them to have some really meaningful work done to prevent future overdose deaths. So when these proposals and pieces of legislation come out, support from this group and those that you work with would be much appreciated.
Great. Wow. Elliot, thanks so much for outlining several things that are currently going on and making our consortium members aware so that they can plug into your efforts. Are there other things that folks would like to mention? I think I saw something
Dr.
about,
Myers.
Yes, go ahead.
Sorry, this is Dr. B. I just wanted to follow up on those comments. Please, please, please reach out to your legislators. There were some fantastic suggestions that were mentioned, and even some in the chat box. If you are in support of any of those, reach out to your legislators and let them know. They're listening, and it does trickle into the policies that the state, enacts.
Thank you for that reminder. I think it was 2 years ago, maybe 3, we actually did a training on how to communicate with the legislator effectively to advocate for policy change, not necessarily specific bills. Many of us are under constraints in that regard, but thanks for that reminder. The legislators are home when they're not in special session before they go into regular session, and we need to take advantage of the time when they're home and in the districts. Yeah, I see you turned your camera on.
Right. The county mayors and county commissioners associations are meeting in Memphis, November 3rd through the 5th to prepare our agenda for our state legislators to take into the session starting this winter. So glad to take any suggestions with us.
Can I send you a summary of the notes that we make from this session and from all day, and you'll have that in your pocket?
Absolutely.
Okay, and I'll share it with Jeff Tibbles too, as someone I talked to, and then you could spread it more broadly, but we could share what we've discussed this year and the prior 2 years.
Certainly. Thank you.
Thank you. I thought I saw a comment, and I'm sorry, I'm trying to scroll through and keep my eye on the cameras, about the restrictions on location of harm reduction sites, or did I dream that?
I put that in the chat.
Okay, you want to say more about that to the group?
Sure, I can do that. So currently, as it is written into law, certain service programs in urban communities or metropolitan areas are required to be 1,000 feet from parks, schools, and greenways, and in rural communities, 2,000 feet from parks, schools, and greenways. And that can provide quite the challenge for folks who are trying to find a space that is usable for harm reduction programming. And as the State Department of Health is increasingly supporting harm reduction programming as a evidence-based way of addressing overdose and related harms. I think that something that would be really useful would be to change what those restrictions look like.
Okay. Sam, one of the things that I frequently, in policy is my practice, one of the things I commonly look at when we're looking at policy changes, understanding what the problem is, how the proposed policy addresses the problem, and then also understanding sort of the contextual factors. Could you say a little bit more about location restrictions and how hard that's going to be and what's going on in other states? Could you offer some more information that would help us understand the context of addressing this issue?
Sure. So from my perspective, the distance restrictions aren't really rooted in any sort of documented concerns. I think that they are relying really heavily on the stigma that we discussed before around substance use, and the types of things that people assume a syringe service program might bring to an area, when the reality is that syringe service programs are deeply boring in terms of what it looks like to provide those services. And it's not promoting substance use, it's not increasing crime in areas, all of these things. There are peer-reviewed sources that refute those claims. And so I think that that is a large piece of where that's coming from. As far as what other communities are doing, I'm not sure what those, if those restrictions exist, what they look like, or how they're written, unfortunately.
Okay. No, that really helped your response. I appreciate it. Thank you so much.
Yeah, absolutely. Thank you.
Okay, so
I'm sorry.
yes, please go ahead, Bethany.
No, I was just going to jump in and say, in terms of the restrictions on where those facilities or where those programming can be, if you look at somewhere that it can't be within it can't be within a certain distance of a lot of major things going on, like it's not likely to be on a bus route either, is it? Which would really restrict, so it might be really hard, extra difficult for folks to get there.
Good point, Bethany. Thanks for sharing that. I see that Kyler has seen a mistake that I made when Mayor Morton was talking about block grants. Were you talking specifically, Mayor Morton, about Medicaid block grants, or were you talking about community development grants?
Well, the language I've heard used is community development block grant.
Right, and I assumed when you said that that was separate from the Medicaid block grants. Is that a correct understanding?
I'm not sure exactly what the governor's approach was, but he worked an effort over a year ago.
Right.
But I would not. I'm not an expert on exactly what the funding streams were.
Okay, well, my understanding is from doing a little bit of work there that had pretty much been on hold from the pandemic, not to say that it won't come back. But I understood that it was meant to align with the Medicaid block grants, but it wasn't a block grant per se. But I think Kyler's comment brings up a really important point that we need to think about the consequences, intended and unintended, with the Medicaid block grant. And Kyler, please open up and talk if you want to add to this, because I think we're looking at something that could have a pretty major impact. Yep. Okay, are there other things?
I think it's worth mentioning provider rate increases are extremely needed, as well as salary increases. We have, it's been mentioned by some here correctly, that we have massive workforce shortages in behavioral health, mental health, addiction, you name it. And I know that there are other parts of many other industries that have shortages. I can say that the behavioral health industry has lagged behind other parts of healthcare for quite some time, and we're seeing surges that we have not seen before in terms of overdosing, addiction, suicide, mental health prevalence, et cetera. So I know that there's been a workforce development work group that's been ongoing, co-led by TennCare and the Department of Mental Health and Substance Abuse Services. And we're expecting to see the recommendations from that group soon. And I know that the provider organizations are excited to see what is put out there in terms of these rate increases. So that's something that's really important and will need some wide support as well.
Mm-hmm. I would probably add, Elliot, at the risk of, maybe I shouldn't say this, but also we need to look at using all the resources that we have. And Tennessee has some of the most restrictive practice authority for physician assistants and advanced practice registered nurses, such as nurse practitioners, and strong evidence from other states that we're able to at least marginally or better increase the availability of services when we remove these restrictions. So
Absolutely.
just add
Absolutely.
that there. Yeah.
No, I think that's great to add, because Tennessee was the second to last state in the country to allow nurse practitioners in any form or fashion to prescribe buprenorphine.
Right.
And that is still in very limited fashion. And we have a major, if we have a shortage of general providers, we don't have anywhere near enough access to medication assisted treatment. And we need to have immediate access in the emergency departments, for example, and just make sure people can get care right away. We have long wait lists, unfortunately, for these residential treatment facilities, and we're missing a chance to help people when they need it.
Mm-hmm. Thank you. And then I see a comment from Lori Meshke, and Lori, it brings up the fact that we need to move off the single provider model and sort of the turf battles and begin to think what's best for patients is a team-based approach where we provide the patient the services they need at that time. And it's not always the same across time. So we need to think about other healthcare professionals that can be instrumental in helping people prevention, treatment, and recovery. So Lori, thanks for that comment about social workers. They're a piece of the puzzle and a member of teams if we could move more to that model of care delivery. So I see that Leslie Marie has states can use, wait, I need to go back further. It's hard to look at people and try to follow the chat at the same time. Leslie Marie, why don't you just speak out here about the federal funds and how the states can use them and what North Carolina has done?
Right, so there is a federal ban on using federal funds for syringes for syringe exchange programs, and for syringe service programs or syringe exchange, whatever you want to call it. We can use state and federal funds for staffing, and staffing is certainly the number one cost, but the number two cost is syringes, and that really limits how programs can work in Tennessee. That becomes a limiting factor of how well we can provide services to folks. But so North Carolina worked to allow state funds to be used for syringes. And I know that has helped several programs in North Carolina serve a lot more people. And so the federal ban, again, is only on federal funds, and but states can still spend money, but we have a state ban.
Okay. Thanks for clarifying that. I appreciate it. Unless there's another question, I'm going to ask a question of Judge Sloan if he's still with us. I'm not sure if he's still able to be with us.
I'm here.
Okay. I'm thinking about the past few years and the things we've talked about. Many of these things are issues we've talked about for several years. Update on criminal justice reform and what you would see as priorities there as we look for people with substance use disorders.
I think the priority is that we have the capacity or the ability to go upstream. And for example, we need more law enforcement diversion programs. I echo that. However, when you do come into a local jail, that everyone have a brief screening to determine if you need services for a substance use disorder or co-occurring mental health disorder, and then the ability to immediately have a more full assessment, and then that warm handoff to a provider when you're coming back out into the community, whether it's within hours, days, or months. That I think will yield more dividends than anything else that I can think of. But of course, you have to have that infrastructure in place and the ability to pay the providers.
Perfect. Thank you. I know we could go on much longer, but I think that's a great place to end.